But okay.
I'm just in the back here. I'm just kind of hanging out.
Okay, so this is my next case. This was, you can see this marked circumferential esophageal thickening with some adjacent lymph nodes. So it looks like a distal esophageal cancer. There was a lesion in the liver, but that turned out to be nothing. And there was also a PET. And one of the pertinent findings on the PET was that there was this paratracheal lymph node, and the esophagus was very avid. And it's basically going to the level of the GE junction. So I wanted to just review something that I'm always confused about, which is the Siewert classification for GE junction tumors. So if you have a tumor that's involving the GE junction, you have to determine if you think it's a Siewert type 1, which is of the distal esophagus, a Siewert type 2, which is of the GE junction, or a Siewert type 3, which is a cardia tumor. So you could have an esophageal cancer that grows down into the GE junction and even into the stomach. But if it seems like it's centered in the distal esophagus, then that's considered an esophageal cancer. And the biggest risk factor for that is Barrett's. If it's of the GE junction, you're not sure. And then if it's of the cardia, but it seems to be growing up, but it's centered in the cardia, then that's a Siewert 3 and it's treated as a gastric cancer. The reason this is important is because there's different treatment for them. So for esophageal cancers, first of all, they do PET often for staging. So in this case, for example, it's very helpful to see this paratracheal lymph node. Although that's still within the potential resection bed because it's near the upper esophagus. They have to change from doing an Ivor-Lewis to a transhiatal esophagectomy. And it's almost if it was a supraclavicular node, that would be a metastatic node. So first of all, they do PET for staging, which they don't do routinely for gastric cancer because gastric cancer spreads more to the omentum and that's more difficult to detect by PET. And they also give chemoradiation prior to surgery. So that's different than gastric cancer where they don't do radiation. There's also two different types of esophagectomy. So Ivor-Lewis is basically they take out most of the esophagus, but they leave the proximal esophagus. And the anastomosis is in the upper chest. And a transhiatal, which is higher, and the anastomosis is in the neck. So that's when they do a complete esophagectomy and anastomosis there. If it's truly just at the GE junction, they basically have to decide if they think it's more likely to be esophageal or gastric. And two of the things that would influence them is if the patient has Barrett's esophagus or a history of reflux, which would make it more likely an esophageal, or if they have atrophic gastritis or H. pylori in their stomach, and then they think it's more likely a gastric. Any comments?
I mean, I think in this place in Mayo, it's most of the type 2s are considered gastric. At least treated like gastric.
Yeah, and actually, this is another interesting point that has come up before, which is that, like, for example, you just said type 2s are treated like a gastric, and if you're basically taking out the GE junction and the vagus nerve, you essentially have to do a total gastrectomy, which is like the treatment for gastric cancer. And I also always got confused about why they had to do this. But one of the reasons is if you take out the vagus nerve, your pylorus basically doesn't work and it can't relax. So most of the time, if they take out the proximal stomach and the vagus nerve, you have to do a pylorotomy. But if you have this, if you anastomose your esophagus to your stomach and you do this pylorotomy, you get a lot of biliary reflux and it's very morbid. So it's actually better, if you're going to do a proximal gastrectomy, it's better to just do a total gastrectomy and have an esophago-jejunal anastomosis. There's less biliary reflux because it's not as close to where the pancreas and the gallbladder will be inserting all their juices.